Now moving on to our last section, that is the dislocation of shoulder. We have discussed the injuries around the shoulder girdle, and mainly now coming to the last of the topics, that is the dislocation of the shoulder. Usually we'll be discussing briefly the different types of dislocation, the most common being the anterior dislocation. Rarely we see posterior and inferior dislocation as well, and how to manage these and what are the maneuvers to closely reduce the shoulder joint. Now coming to the dislocation of the shoulder. Due to this could be number of factors. Now when you see the anatomy of the shoulder, it's called as a ball in the teacup kind of a joint, in which the teacup is a big one and the ball can freely move. So it's actually this kind of situation. It is R ball over the T. If somebody is an avid golfer, you would probably know that what's the T. It's a very small sign. If you use this, the glenoid cavity acts as a T and this head acts as a ball. It's a little more than this gives it a free range of motion. Therefore that is why so much movement is actually possible at the shoulder joint. But at the cost, it also inherently puts shoulder at a bit of a the dislocation, because it inherently makes the shoulder joint unstable. So this is how what results in there is actually shoulder dislocations are very common, usually seen in the ER departments. Factors could be shallowness of the glenoid socket. If this glenoid socket is too shallow, that would preclude the shoulder joint to either easily dislocate out of the socket. Extraordinary range of movement, usually patients those who have ligamentous laxity, such as Ehlers-Danlos syndromes, they have actually hypermobility at the joint, and with inherently unstable joint which is already designed to give you a lot of movement, and when there will be excessive movement, this will push the head out of the glenoid cavity. Now coming to the underlying conditions such as ligamentous laxity is also one of the causes, and vulnerability of joint during stressful activities of the upper limb. Sometimes the cause could be simply traumatic as well. There could be so much forces which could be acting on this, which could dislocate the head either anteriorly, posteriorly, or inferiorly. Now coming to the most common dislocation of the shoulder, that is the anterior dislocation. If you see, this is the normal anatomy. This is the tendon of the rotator cuff is there, and the tendon of the bicep is actually coming through the rotator cuff, and it can be displaced anteriorly in such a way that just subcoracoidally head is possible, and this instead of being over here, and glenoid cavity is actually empty. The mechanism of injury is by fall on the hand, and usually the head of the humerus is driven forward and subcoracoidally. This results in tearing of capsule anteriorly, leading to a Bankart type of a lesion or anterior lesion. This could also result when this head strikes this area of the scapula. This could result in the posterior lateral injury of the head as well. And this part get crushed and later on get dissolved, eventually leading to classical type of pattern called as hillside lesion. So inferiorly it's the Bankart where the capsule gets ruptured, and posterior superiorly it's on the head, which makes it the hillside lesion and leading to luxation erratica. Now the clinical features in case of the anterior dislocation, as the head is actually more anteriorly, the arm is adducted with externally rotated, and as the head is lying anteriorly, the definitely internal rotation of the arm is not easily possible. The patient may be very much in severe pain. Lateral outline of the shoulder, usually the deltoid cavity is actually gone. Bulge can be felt just below the coracoid, which is actually the humerus head. An examination of the nerve and vascular injury is mandatory because we have to see the patient as such. We have to see the patient as whether it's associated neurovascular injury or not. Usually the x-rays, if you see this x-ray, this is how the AP view would look like. What head would be more prominent, more towards the chest and the clavicle, and you can appreciate the glenoid cavity would be empty. Anterior posterior x-rays usually show overlapping shadows of the humeral head and the glenoid fossa. On the lateral view, we see a long blade of the scapula. It shows the humeral head outline with the socket. Ideal, there are different x-rays which can be done as well. One of the common is axillary views or the scapular Y views. On a scapular Y view, such a lateral Y view, the scapular blade looks like a shape of a Y, and we can appreciate if it's out of the socket either anteriorly or posteriorly, and that is actually tells us whether anterior or posterior dislocation as well. Special views, there may be a flattening or even excavation. of posterior lateral counter of the humeral head as well, indicating it's a Hill-Sachs lesion. But usually acutely it may not present as it, but over the chronic recurrent dislocation, once the capsule has ruptured completely and there is continuous dislocation of the head anteriorly, there may be a posterior laterally on recurrent dislocation. You see a Hill-Sachs lesion at times as well. Coming to the treatment, acute dislocation needs to be reduced closely. Close reduction, if it's impossible or if not been able to achieve, then we have to go for open reduction of the shoulder joint. But close reduction could be simple traction on the arm, sedation, and occasionally general anesthesia may also have to be given. There are multiple methods actually for shoulder reduction. One of this is the Stimson's technique, as you can appreciate over here, in the which you're lying prone, arm is hanging by the side, and either you attach a weight over the top of it, or you ask some of one of your colleagues to hold the arm and apply some traction over it so that it gets reduced. Other option is that you patient is on GA, his patient is prone, and you attach some amount of arm and leave it there for 10 to 40 minutes. And eventually, after half an hour to 45 minutes, the shoulder will be reduced by itself when the muscle gets relaxed. This is one of the first method which was actually called as Hippocratic methods, although it has its own pros that you do not need an assistant sometimes, and patients, if you are only one over there in a peripheral hospital, you don't have any assistant, then you can do this sort of method. But the bad part over there, the cons of this is when the foot is actually utilized to actually provide contraction, this can actually result in a brachial plexus injury, which could be a disaster for the patient, because patient came in with a neurovascular intact, but then later on developed a brachial plexus injury. Other is a Kosher method, which is more commonly routinely utilized and it's actually the patient is lying supine. The patient is either sedated or usually rarely general anesthesia is given, but sometimes you have to give that as well so that the muscles can relax completely. Arm is held in a hand. It's slightly, the formula is actually the tear. That is, slight traction is applied, arm is external rotated, then abducted, and once abducted over the head, then internal rotated so that the head rocks back into the glenoid cavity. And usually with the Kosher method is more commonly utilized, and it easily reduces the head back into its socket. Now coming to this is how the Kosher is actually applied. The only problem is that most of the time the patient is actually under the sedation. Abduction is gently used, actually gently tested. And why we need to test this abduction? Because we need to whether there's severe neurovascular injury or not. Some things, when we are examining the patient's anterior dislocation, the first and foremost is we need to rule out neurovascular injury. That is to exclude axillary nerve injury and rotator cuff tear. Then testing the nerves, all the median, radial, ulnar nerve must be tested, musculocutaneous nerve must be tested as well, and pulse must be found. So if the patient has isolated anterior dislocation with no neurovascular injury, then you closely reduce the injury. Now coming to the treatment, if the rate of recurrent instability, if the recurrent instability in form anterior instability or posterior instability, then we have to look at this Hill-Sachs lesion size. Hill-Sachs lesion is actually a lesion which is formed in the posterior lateral aspect of the humeral head due to recurrent dislocations. Usually elbow and finger movements are practiced. Initially rehab is done. External rotation splints can be utilized as well, and sometimes arthroscopic repair of the Bankart lesion can also be done. And if the patient is having a recurrent instability, then we can go for inferior capsular shift as well. But if it's an acute injury, then probably we can go for Bankart surgery. But if it's recurrent instability, a recurrent injury, a recurrent dislocation, then probably inferior capsular shift is the ideal choice of the treatment. Coming to the complication, include rotator cuff tear, nerve injuries, or vascular injuries, or even could be fracture dislocation as well. Late includes shoulder stiffness, unreduced dislocation, or recurrent dislocation as well, because there may be associated capsular tear or Hill-Sachs lesions, and this may lead to recurrent dislocation at times as well. Now coming to the posterior dislocation, although it's very rare. Posterior and inferior dislocation is rare, but it can occur in certain situations, especially due to severe indirect force caused by internal rotation, force acting in adduction at times as well. Now this is classically happens is that the arms are internally rotated and there is a lot of adduction forces actually acting on the shoulder, and this is very much common in either in electrocution injury or electric shock, or in case of convulsions and fits. The patients usually with either having an electric injury or a convulsion injury is usually present with posterior dislocation. And it could, although it can happen, but although it's very rare, the fall on the flexed arm, because usually it's either on the outstretched arm, and then this can lead to different types of clavicle shoulder injuries. But if a patient has fell on a flexed arm, then this can lead to because in flexed arm there's adducted arm and internally rotated shoulder, so that can result in a posterior dislocation. Or rarely it could be direct blow to the front of the shoulder or fall on outstretched hand as well. But usually that results in different types of fractures as well. Now coming to the clinical features, the posterior dislocation, arm is held in internal rotation and patient cannot externally rotate it. Once tries to externally rotate it, is highly completely painful. Arms are locked in the internal rotation and adduction position. Front of the shoulder looks quite flat, and usually as the head of the humerus has gone back behind the glenoid cavity, the coracoid becomes very prominent. Usually sometimes this is although rare, but sometimes this swelling may be so massive that coracoid prominence may be obscured as well at times. The displacement is usually apparent and we can appreciate the head has actually gone back. Coming to the imaging, again, if you see this, something the straightforward is an AP view of the shoulder. Although if there are different images, on AP view, humeral head is medially rotated, looks abnormal in shape at times, and there is an ampli-glenoid sign may be seen as well. But sometimes we need maybe have so much just subluxation or dislocation, maybe so little that we may not be able to visualize it. Then we may have to go for other x-rays, which includes axillary views, lateral frame, scapular views, which actually tell us whether there is a completely anterior posterior dislocation or not. So deep indentation of anterior aspect of the humeral head. But the classical way, if you're still not sure despite the views, is to go for a CT scan. And CT scan would exactly tell whether the anterior or posterior dislocation with the 3D reconstruction. Now coming to the treatment. Treatment, if it's acute dislocation that has to be reduced, then as per different methods of Stimson's, Koshers, and there are different techniques for reduction of posterior dislocation. Then arm has to be immobilized in a sling, shoulder held widely abducted as well. Laterally rotated airplane type of splint can be utilized, but now there is actually the studies have proven whether you give external rotated splint or internal rotated splint, that makes no big difference eventually and in the rehab. So both type of splints can be given, and movements have to be regained by active exercises, and once so that the stiffness of the shoulders can be avoided and rehab can be easily constituted. Now coming to the inferior dislocation, again it's a very rare, but it's called as luxatio eretica. This is the mechanism of injury is by severe hyperabduction of the force, in which the arm was already in hyperabduction and there was so much force which occurred in resulting in the humeral head being displaced inferiorly below the coracoid. This could be humeral head could be lifted across, leading to inferior rim of the glenoid socket injury. If you see this, the arm was abducted, this is the acromion, this is the, and the force was acting in this direction, and there was so much violent force, the inferior, the capsule got ruptured, the humeral head dislocated just inferior to the coracoid. Usually, if the head is usually in the subglenoid position, associated with severe soft tissue injuries, and this can actually damage the brachial plexus and axillary artery as well. Clinically features is actually the patient is arm is locked in almost full abduction. Patient cannot adduct its arm because adduction arm would actually impinge the head and cause a lot of pain. Humerus head is actually below the axilla, just below the coracoid, and examination of the neurovascular must be done, may be associated with neurovascular injury as well. Now again, if we get on simple AP X-rays, if you see this is probably showing that you can appreciate whether the glenoid cavity is there as well as the humerus head is displaced out. Well, but this is actually the X-ray of an anterior dislocation. If it would have been inferior dislocation, the arm would be in abducted position and head would get displaced at times. Humeral shaft is abducted position, head is below the glenoid, and what we have to search for is associated features of glenoid fracture. fracture of the proximal humerus as well. Usually this is a high energy trauma, especially the patient has either holding onto it, or there was a lot of weight which was falling, and the patient tried to protect his head. And arm was at that time in such an abduction that a lot of force was acting on the head and resulting in inferior dislocation. So treatment is actually the first and foremost is if it's inferior, it's posterior, anterior. If it's a closed dislocation, we need to reduce it closely. If we cannot reduce by closed maneuver, then we have to go for open reduction at times as well. Counteraction is downward over the top shoulder technique as well. Then open reduction techniques are also available if we cannot completely reduce it by closed maneuvers. And after the reduction, we have to examine the patient for neurovascular injury as well. And then once we have closely reduced it, we can sling the arm for 2 to 3 weeks in a sling, and then we can start the early range of motion at 3 to 4 weeks at times as well. Now coming to the shoulder dislocation in children, although in children they usually that may be due not because of the trauma, but maybe due to the ligamentous laxity as well. So it could be in form of voluntary and involuntary dislocation. Voluntary includes us demonstrating stability at will. You ask the child to dislocate the shoulder and he's going to do a maneuver and dislocate his shoulder anteriorly posteriorly. Involuntary dislocation is that shoulder slips out when he or she is doing the activities of daily living. This may be due to underlying ligamentous laxity, or this may be underlying maldevelopment of glenoid cavity, which is too shallow, or the head is either, there may be something wrong with the head as well, so that it slips out quite easily. So the treatment is actually depending upon if it's an atraumatic dislocation, that has to be viewed with great caution, especially in the case of the children. And sometimes we have to go for prolonged exercise programs. Reconstructive surgery is usually done, but that is actually the child is generally distressed, and psychological fractures are the ones ruled out. And usually this is reserved for older children once they can actively participate in the rehab program. In this section, I've briefly gone through what are the different types of shoulder dislocation. The anterior shoulder dislocation is the most common one, although shoulder can dislocate posteriorly and inferiorly as well. Anterior, the foremost method of shoulder dislocation is to go for close reduction maneuvers in acute injury. If we cannot reduce it closely, then we may have to go for open reduction maneuvers as well. The usually methods for anterior dislocation are Stimson's, Kocher's, and Hippocratic methods. Similar is the case with the posterior dislocation as well. The problem is with the posterior dislocation usually associated with convergent fits or electrocution injury. And the bottom line of the treatment most of the time is actually this closely reduce these dislocations, apply sling for 2 to 3 weeks, then start gradual range of motion, and over 4 to 6 weeks, then later on you can start some degree of abduction. Abduction may be held up till 12 weeks as well at times, so that once the capsules are completely healed, then we can start the abduction of the shoulder. Thank you very much. Keep watching sqadia.com.